Hi, it's really great to be here. The Black Women's Health Study was begun over 30 or almost 30 years ago with the goal of elucidating modifiable risk factors for the myriad of health conditions that are disproportionately affected or affect Black women in the US. Huge. And my colleague Lynn Rosenberg and I were women's health researchers in the 80s and 90s, and we were well aware that most of the women's health research in population sciences was being conducted in white women. We wanted to do a different type of study. In 1995, 59,000 self-identified Black women enrolled in this study by completing a 14-page scannable questionnaire. So lots of data on that. Since then, they get questionnaires every 2 years for follow-up data. Questions include body mass index, health behaviors, experiences with racism and other stressors, health conditions, medications, lots of other things. Early on, we also geocoded participant addresses so we could link to national databases and have information on the social and economic characteristics of the neighborhoods in which people lived, also the environmental toxins, green space, et cetera. At the other end of the spectrum, we were collecting biologic samples, so saliva as a source of germline DNA and blood samples as a source for plasma and serum biomarkers. The study has been primarily funded by the National Cancer Institute because of the critical need to answer the question of why mortality from breast cancer is so much higher in Black women than white women in the US. And as you can see on the slide, the curve, the top two lines are, the top one is the highest mortality in Black women, even though it's decreasing over time in both groups. The difference represents a 40% higher mortality in Black women than white women, despite the fact that incidence is similar. We've been taking a multi-pronged approach to understanding this. Today, I'm going to talk about our research on place. So I mentioned before that we geocoded addresses. We were able to use Census Bureau data and factor analysis to compute a neighborhood disadvantage score for all the participants in the years before breast cancer occurred. And then what we found was that women who lived in the most disadvantaged neighborhoods, and we broke it into quartiles, were estimated to have a 25% increased risk of developing estrogen receptor negative breast cancer versus those who lived in the more advantaged neighborhoods. And that's important because that type of breast cancer is twice as common in Black women as white women or other groups. It's more aggressive and more difficult to treat. We've also been looking at neighborhood in relation to breast cancer mortality. You can see here, if you follow the survival curves, that the lowest quartile or the highest quartile of disadvantage, which is the bottom curve, those women have the worst survival or the highest mortality. And that is not accounted for by stage of diagnosis or tumor type. So we don't know the reasons why, but as the previous speaker talked about biologic effects of stress and that whole cascade, I don't have to go into it, but we suspect psychosocial stress has something to do with effects in all of these. Our team is continuing to work on all aspects. Thank you very much.